Assalamualaikum and good morning to Dr. Anne Franks. So I will start with 2019 Group A SBAQ. The question is 74-year-old 74-year-old man presented with a weak postprandial abdominal pain and diarrhea. And then his past medical history include atrial fibrillation and ischemic heart disease. A
Haziq boleh
recent
besar sikit tak? Tak nampak.
Sekejap. Nampak doktor?
Nampak. Lepas tu you buang sikit ada covered. Oh sebab gambar ni screenshot. 74 you.
Ada
Presented
yang
with
tak
apa?
tulis.
A week?
Cuba ambil bawah sikit, ada tulis. Saya ada tulis. Tu, a weak postprandial abdominal pain and diarrhea.
Okay, and then atas?
Atas tu, saya ada yang tak nampak agak.
Okay.
He has, tu saya tak tahu. Lepas tu, his past medical history include atrial fibrillation and ischemic heart disease. And then esophagogastroduodenoscopy and colonoscopy were normal. And then for the information, he is old, anemia, leukocytosis, hyponatremia, high creatinine, atrial fibrillation, and ischemic heart disease. So the best diagnosis investigations, since I expect patient had acute mesenteric ischemia, I will go with bawah sikit. B, contrast enhanced complexity tu.
Okay. Kenapa
Okay.
jawapan, okay selalunya when do we do, the diagnosis is correct, acute mesenteric ischemia. The risk factor for mesenteric ischemia in this case adalah? One of the yes, it's the atrial fibrillation mainly. Okay, right. So kenapa jawapan okay, so yang lain-lain tu salah, you tahu kan what's the use for barium enema, basically to look for blockage. Kalau you dah buat colonoscopy, so there's no need to do sigmoidoscopy, macam tu. Okay, so okay, sekarang ni we know that the diagnosis is acute mesenteric ischemia. So this is diagnosis, so this is kira macam level 1 of question. So in your setting, for your exam, kita takkan tanya dah soalan diagnosis for acute mesenteric ischemia in terms of diagnosis. So mungkin soalan kita boleh tanya in terms of management. So you rasa kalau management, what would usually kalau third year is the first line of management. You rasa kalau acute mesenteric ischemia, what would be the management that we can give to the patient? You boleh tengok buku kalau
Ya, ada tu.
Buku Oxford Handbook je tau. Jangan go beyond that. Mainly SBAQ adalah Oxford Handbook.
So you let them share it.
Usually the treatment for acute mesenteric ischemia depends on the degree of the damage. Kalau memang patient memang dah ada bowel ischemia to the point of having gangrene and then they're clinically unwell, memang kena pursue operation and do a colectomy atau hemicolectomy macam tu. Then subsequently has to be started on anticoagulation, like heparin as well as long-term warfarin. Okay, next.
Okay, Next question. A 17 years old woman presented for her first time with multiple bruises on both lower limb. There was no history of trauma. Systemic examination was unremarkable apart from multiple ecchymosis patches seen on her lower limb bilaterally.
Dah bagi I baca
Was
sekejap. Sekejap bagi I baca sekejap. Okay, good. So, investigation.
so
Before that
investigation.
kan, the investigation for FBC, RP, LFT, coagulation profile. So, apa lagi you all kena hafal. Sekejap, give me a second. Sekejap So, yang you all kena hafal adalah FBC, RP, calcium, phosphate, magnesium, LFT, coag. I bagi kat you all lah this list. I bagi kat you all the normal value kita siap-siap.
Okay, doctor. Thank you. Okay.
Lepas tu?
Okay, so
dia punya finding. Okay.
Information dia, patient was anemic with thrombocytopenia and also prolonged prothrombin time. So the answer is C, idiopathic thrombocytopenic purpura.
ITP. Usually, yes, ITP lah, idiopathic thrombocytopenic purpura. The PT tu memang betul. Kalau you tengok value sini memang nampak macam prolong sikit. Tapi actually, it's not that. Kalau in clinical practice, kita tak jump lah on this value. Kita jump on more obvious value. So, macam this one yang paling more obvious will be 40, which is a platelet. So, what are the other choices? A, B, C, D, tengok.
A, B, C, D, aplastic anemia.
Okay, so kenapa bukan aplastic anemia?
Because the normal
Usually kalau
sorry.
Cari what is the definition for aplastic anemia? I share the normal values dekat dalam group.
Okay.
The definition for aplastic anemia adalah all the 3 cell lineage tu turun. So you have low HB, low total white and low platelet. Aplasia tu meaning the marrow cannot produce the 3 cells. And then why is it not dengue fever in A febrile?
Normal thrombin time. The thrombin time is
I don't think so. Tengok jap dia punya stem dekat atas tu. Okay, the reason why it's not dengue fever sebab dalam history tu tak ada history. Kalau dengue fever kita memang akan bagi history of fever dekat you all. Presented with history of fever for 1 week and then has become afebrile macam tu. Memang ada history of fever. Okay. Bukan sudden. Tiba-tiba sudden lah kan. Sort of like incidental finding of bruises without any other complaints is not dengue. Dengue usually unwell first and then only they will have petechiae and etc. Lagi? D apa?
This because in Willebrand disease, the platelet should be normal.
Yes. Okay. Von Willebrand,
Uh,
the findings are usually normal. Bila we suspect when they have increase in bleeding tendency despite normal investigation punya finding. Von Willebrand disease ada 3 types, right? Satu is reduce in the factors, and tu you all tak payah, and tu you all just tahu roughly cukup lah. Tapi you only have to, the fact that you know that platelet should be normal tu, then you carry out VWD, that's good enough. Okay, so the other way that we can ask this question is, what would be the best investigation in this patient? What would be the best diagnostic investigation in this patient? So you dah tahu dah diagnosis dia adalah ITP. So you rasa the best investigation to send apa? You do a full blood picture.
full of picture. Okay.
Okay. Alright. Lagi turun. So kalau lah sorry. Kalau soalan macam ni keluar dalam you punya short answer question, we all dah bagi value FBC and then the coagulation punya value dengan LFT. When we ask you what are the investigation to send, you never repeat the investigation that have been given. Students have the tendency to repeat. They feel like putting as many answers as they can in the answer sheet somehow will impress the examiners. It doesn't work that way. Okay. So kalau you nak letak jawapan lebih daripada kita orang minta 3 and then you nak bagi lebih dari 3, tak ada masalah. That is up to the discretion of the examiner. Some examiner dia akan baca lebih, some examiner akan baca sampai 3 and then stop. Tapi you never repeat. Kalau dah ada LFT kat atas, you never say LFT again. Or kalau memang dah ada chest x-ray kat atas punya finding, you never say chest x-ray again. Okay.
Okay, doctor.
Alright, next.
Okay, a 55-year-old man presented with bilateral feet pain. He described it as burning in nature. On examination, he had full power in both of his lower limb, but there was reduced sensation up to his mid-shin. The most likely diagnosis is C, peripheral neuropathy because of the age, and then burning like bilateral feet pain and the reduced sensations.
Okay, good. Why is it not A, B, and D?
Because usually kalau the equina had urination problem,
Good,
and patient also had no saddle anesthesia,
good.
and then for motor neurons, patient does not have slur speech, and usually it contains weak grip in motor neuron disease.
It contain, sorry, what?
So patient usually had weak grip in
Weak grip.
motor neuron.
Okay, usually the presentation that we will put in an exam for MND adalah a combination of both upper and lower motor neuron. And for quadra equina, the usual presentation that we will put is somebody with a recent, it's an acute onset, acute. It's not something yang dah subacute ataupun dah chronic. Quadra equina is usually acute sebab suddenly tak boleh kencing and berak, and usually ada sudden precipitating by trauma. Okay, what about polymyositis?
Is it because patient does not have fever? And then,
The answer is no. Polymyositis rarely present as fever. They normally present as muscle. They normally present as proximal weakness because it's a muscle group. So poly and dermatomyositis usually proximal weakness, as in contrast to peripheral neuropathy, which is usually distal. Okay. So the other type of questions that we will ask in this case if we were to repeat this question, is what would be the test that you would want to do to confirm your diagnosis of peripheral neuropathy? Cuba you buka peripheral neuropathy dalam Oxford Handbook tu, you tengok what
Is it
test to.
nerve conduction test?
Yes, you do a nerve conduction study. Okay. Kalau quadra equina, what test do you do? Quadra equina, you do an MRI of the spine. Polymyositis, the test is actually a muscle biopsy. Okay, good. Next.
A 32-year-old woman presented with oligomenorrhea, facial hair, and acne for 6 months. She subsequently developed back pain and was found to have compression fracture of the lumbar spine. Select the most likely diagnosis. The answer is A.
Okay.
Boleh turun bawah sikit. Yeah, the explanation is because of the clinical feature of Cushing syndrome, like the oligomenorrhea, hirsutism, and also acne. And
Good.
then due to the Cushing syndrome, there is increased bone resorption that cause the fracture to the lumbar spine.
What is the other diagnosis for increased bone resorption in Cushing?
Sorry?
Increased bone resorption in Cushing causing
Okay.
fracture tu, there's an unifying diagnosis to that. It starts with the word O.
Oh, osteoporosis ke?
Yes, osteoporosis. Okay. So what about B, C and D? Okay, kita start dengan C dulu. Kenapa dia bukan polycystic ovarian syndrome? Sebab PCOS pun boleh dapat oligomenorrhea, facial hair.
Because dia tak kacau dia punya
Betul.
calcium.
Betul. Sebab PCOS is not systemic. PCOS is only in the cutaneous manifestation as well as the genitourinary. Gonadal, sorry. What about premature ovarian failure? Usually what would be the typical presentation? Premature ovarian failure, usually the presentation is memang tak datang period daripada awal. And dia tak ada secondary characteristic daripada awal. Small in size and then tak ada body hair, tak ada the pubic hair, the axillary hair, and tak datang period lah daripada awal. Okay. Prolactinoma. What would be the usual presentation of prolactinoma? Tak dengar. Dengar lah.
Doktor, dengar?
Tadi macam putus-putus.
Usually prolactinoma dia akan ada macam presentation of bitemporal hemianopia, doktor, because It's affect the pituitary gland.
Betul. And they can have increased milk production. Alright, next. Okay, sorry. So investigation, first line So for Cushing, you have screening as well as diagnostic investigation. So what is the screening for Cushing?
Doctor, for
Yes.
Cushing, we use the urine and saliva 24-hour cortisol level test,
Saliva.
suppression test.
Urine or saliva? Uh, I don't remember doing saliva in endocrine. Tapi the standard one that we use for screening is the 24-hour urinary. Please check again if I'm wrong. 24-hour urinary cortisol, that's for screening. Tapi to confirm, you have to do the 24-hour dexamethasone suppression test. But please check again lah. Okay. Lagi?
Doktor, kalau low dose and high dose dexamethasone suppression test to differentiate either Cushing syndrome or
Sorry. Low dose. Confirmatory is low dose tu. Low dose dexamethasone suppression test. High dose tu kalau nak tengok sama ada dia Cushing or the site of the Cushing. Yang tu you all tak payah tahu. You all hanya tahu setakat confirmatory saja. Okay, kalau for premature ovarian failure and polycystic ovarian syndrome, what test do you, okay, for premature ovarian failure, what test do you say?
we can do the ultrasound, doctor, at the ovarian.
For premature ovarian failure, the diagnostic test is actually to send for FSH dengan LH. For polycystic ovarian syndrome, the investigation that can be sent adalah FSH, LH, serum androgen and ultrasound of the ovaries. Prolactin you send for prolactinoma, you send for prolactin level. Okay?
Okay, doctor.
Alright, next.
A 38-year-old woman presented with a weak history of fever, dysphagia, and maculopapular rash on her trunk. He had unprotected sexual intercourse with her partner about 7 weeks ago. On examination, there were multiple cervical lymphadenopathy. For the hemoglobin, she had anemia, and then normal white cell count, normal platelet, and then other thing is normal. Most likely diagnosis A, human immunodeficiency virus seroconversion.
Okay, good. Okay, so your reason for HIV seroconversion is correct. Usually seroconversion will happen after weeks, like 2 to 6 weeks after the exposure to previous HIV patient. IM, infectious mononucleosis, what would be the usual presentation?
Sorry, doctor?
Infectious mononucleosis. Kenapa bukan? the usual presentation for IM is we will give the thing macam dalam history patient ni, you all kena ingat for SBAQ all the 4 answers are correct. Tapi satu is the most correct. Dia bukan satu correct 3 salah. Macam tu, faham tak? Dia macam if you were to put a differential diagnosis for your long case, you can put all these 4 if let's say you were to get this history for your long case, contoh. Okay. But which one is the most yang very very correct? So it will be HIV seroconversion. IM is a diagnosis that you should consider. Usually IM, kalau in this case a weak fever is possible. Maculopapular rashes is possible. That can happen in IM. But usually the maculopapular rashes in IM, the typical history is after they have taken a specific antibiotic, which is ampicillin. Okay. For IM, we would be putting any history of unprotected sexual intercourse because that would be irrelevant. Ada kaitan dengan dysphagia. They can have lymphadenopathy that can happen in IM. But the other thing that we will put in IM also that there would be splenomegaly. They can have a bit of raised liver function test, and monospot test is a test for IM. So that would be positive. Okay. What about C, Haziq? Mycobacterium tuberculosis?
Easily TB will have respiratory punya presentation macam cough. Good.
Yes, good. And the other thing is, if let's say you're talking about TB in HIV, usually it's a miliary form of TB. So kalau miliary form of TB, they would present as maculopapular rashes. Maculopapular rashes, you all Google up the picture right now. You all will see it's sort of like a patch of erythema, just some diffuse merah satu badan macam tu. So that's maculopapular rashes. Kalau miliary TB, kalau you were to Google up the picture, it's more of like dot kat badan macam tu. Or they can get like necrotic papules kat badan macam tu. Okay, so it's not maculopapular rashes. And of course, yes, we will give history for you guys punya level third year, kita akan bagi history of respiratory involvement. Okay, what about secondary syphilis, Haziq?
Usually patient akan ada ulcer dekat dia punya genital organ and also at mouth.
Betul. Okay, so kalau kita orang nak letak history of nak letak diagnosis of syphilis, we will give, to be fair for you all, we would give a history of chancre, which is a painless ulcer dekat dia punya penile or vulvar area. But they can present, they can have fever, they can have the rashes, maculopapular rashes, or any other types of rashes during secondary syphilis. They can have lymphadenopathy. Usually the lymphadenopathy for secondary syphilis is more localized. Kalau dia ada chancre, then it's usually over the chancre over the genital, then it's usually over the inguinal punya lymphadenopathy. Investigation wise, the anemia tu maybe tak ada kaitan, I mean for syphilis ada pun tak, doesn't make a difference macam tu. Okay, good. Next.
A 22-year-old man presented with nocturnal fever, cough and hemoptysis for 2 weeks. On examination, his temperature was 38 degrees Celsius with crepitation heard over right middle zone of lung. Chest radiograph show a middle lobe atelectasis and increased bronchodvascular marking. Select the most appropriate next diagnosis investigations. D. Sputum acid fast bacilli direct smear.
Good. Okay.
Because patients had active TB infections.
Good. Okay.
For Mentuk test dia untuk latent, so tak boleh guna.
Good.
And then
Mentuk
ESR
test is more towards screening of latent. Okay. ESR?
Motor inflammation je. Jadi macam tak motor diagnosis. Dia boleh je guna tapi tak menghala ke diagnosis punya investigation lah.
Betul?
Sama juga dengan coagulation profile.
Betul? Okay. So usually in this type of question, the next one that we will ask is what would be the next best treatment? Okay, kalau stem tu kita tukar jadi dia ada massive hemoptysis. Hemoptysis has been going on for 2 weeks but presented to ED with massive hemoptysis. Lepas tu on examination dia ada hemodynamically stable tapi cuma dia hemoptysis banyak. So what would be the next best treatment management? Kalau dia ada blood transfusion ataupun dia ada IV drip ataupun dia ada tranexamic acid ataupun dia ada fresh frozen plasma FFP. You rasa apa yang you nak bagi jawapan? Somebody yang ada massive hemoptysis tapi hemodynamically dia stable.
Tranexamic acid tu.
Betul, tranexamic acid. Kalau I letakkan the stem tu hemodynamically unstable, what would be the next best treatment?
Is it using IV drip dulu, Doktor?
Yes, IV drip dulu. Kalau tak respond, then you kalau tak respond and memang ada drop in HP, then you boleh consider for transfusion. Okay, good. Next.
A 45-year-old man with diabetes was admitted for uncontrolled hypertension. His serum creatinine on admission was 280 micromole. Select the most useful investigation to differentiate acute versus chronic kidney injury. B. Serum parathyroid hormone.
Why?
Why? Because in CKD, there are decrease in activation of vitamin D. So untuk kita tahu sebab apa kita kena pergi tengok dekat dia punya parathyroid hormone.
You naik atas balik. Sekejap.
Decrease serum calcium cause increase in serum PTH. Macam tu.
Betul. Kenapa I rasa macam urea? Nanti I get back to you. This ni I tanya nephro punya orang dulu. But I think it's the urea yang you dapat the disproportionate urea to creatinine. Kalau it's more than 20:1 tu. The disproportionate, kalau dia proportionate meaning dia chronic. Kalau urea tu is proportionate, maksudnya you times 20, urea times 20 you dapat lebih kurang the value of the creatinine, maksudnya it's chronic. Kalau urea tu is disproportionate meaning it's acute kidney injury. Tak apa, this one I'll get back to you, tapi jap Apa next question?
A 72-year-old man presented with painful right knee for 3 days. On examination, his temperature was 37.3 degrees Celsius and his right knee was hot and swollen. His white cell count was 12.6. And then plain knee radiograph revealed reduced joint space and calcification of the articular cartilage of right knee. Select the best diagnosis investigations. We go with C, joint aspiration and culture, because I suspect patient had rheumatoid arthritis. No. Sorry. Septic arthritis.
Good. Uh, selalunya the whenever a patient ada soalan macam ni selalu keluar untuk rheumato tau. Sebab we want to emphasize to you all yang all painful and warm joint, you have to rule out septic arthritis first before you think about the other inflammatory conditions. So that's why you always have to start with joint aspiration and culture. Okay, but the diagnosis, rheumatoid arthritis is a bit unlikely because what is the usual presentation for rheumatoid arthritis?
If we do the PE, we can see the swan neck deformity and then rheumatoid nodule at the hand. And then the morning stiffness is prolonged, but sebab tak ada dekat dalam information, so I think we can rule out the rheumatoid arthritis.
Ada tanya gang nephro, the answer is urea. Tadi. Sebab itulah the reason is that one. Kalau disproportionate, maksudnya you times kalau disproportionate urea to creatinine. Okay, not the serum thyroid hormone tu lah. Okay, tak apa. Kalau rheumatoid arthritis, usually the usual presentation it's symmetrical. It's not one joint. Symmetrical, small joints of the hand, sparing the proximal. Sparing the distal, involving the proximal, MCP and the PIP. So that's the usual presentation, and then kita akan letak perempuan umur dalam 40 to 50s with early morning stiffness. And the duration is definitely not subacute ataupun acute like 3 days lah. The duration is definitely will be longer because it's a chronic condition. Kalau what about, can this be gout? Acute gout?
Usually the gout at the sigmoid bone and big toe punya joint.
Sigmoid bone kat mana, punggung?
Sesimod.
Kat mana tu?
Bone yang dekat kita punya ibu jari tu bawah sikit tu.
Apa tak nama bone tu aku tak ingat. Mana sisi dekat punggung kan tak? But anyway, tapi betul is the involvement of the big toe. That's the usual presentation I akan letak you all. But single joint involvement can also be gout. The other one is the other one yang lawan gout tu yang gout dia dapat negative bifringence crystals kan under microscopy. The other one is positive bifringence tu, associated with hypothyroid, hypercalcemia. And tu pun is also a possibility. I tak ingat apa diagnosis dia. Okay. Alright. So the answer betul lah, it's C. You never do ultrasound of the knee to diagnose septic arthritis because mainly you will only see increase in infusion. ESR sama je macam jawapan tadi, it will help in the management but it's not diagnosis. Blood culture, not necessarily they will be spilled into the bloodstream, so blood culture can still be negative. Okay, just nak tambah, so yang tadi yang untuk CKD tu, dia darab 15 to 20 lah. Urea tu you darab 15 to 20. So kalau you dapat, kalau urea you 10 and then you punya bacaan creatinine tu 150 to 200, so maksudnya CKD lah lebih kurang. Tapi kalau lah urea you 30 tapi bacaan creatinine you 150 ya, itu acute kidney injury lah.
Okay, Doktor.
Okay, next.
A 26-year-old man was referred for evaluation of his heart murmur. On examination, he had arachnodactyly and high arch palate. Select the most likely valvular heart lesion in these patients. The answer is A, atrial regurgitation, because I'm expecting patient to have Marfan syndrome.
Alright. Tricuspid sorry. You all kena tahu a few syndrome in cardio. Kalau Down syndrome associated with VSD, and then kalau Noonan syndrome dengan satu lagi yang perempuan tu, Turner syndrome. Kalau tak salah they are associated with pulmonary stenosis, but please check again. Okay. And then you have to know the usual characteristic. They will have a lot of characteristics muka macam mana, tapi they are the common ones. Contohnya kalau macam Down syndrome, the one that we would normally use is the slanting of the eyelid, ataupun tangan dia tu palmar crease dia tu reduce, macam tu. Lepas tu kalau si Turner, the one that we would normally describe adalah dia ada something dekat shoulder rasa. Something dekat dia punya back, macam some sort of like a hump, macam pushing punya hump tu. Dia ada that fat punya benda juga dekat belakang. Yes, sorry, web neck. Yes. So that's his usual presentation. Noonan, if I'm not mistaken, is actually a male form of Turner. But go back and read up. I pun dah tak ingat dah in detail, but just go back and read up these 4 syndrome. Just know roughly the common presentation and the murmur associated with them. So the next question kita akan tanya you all, kita tak akan tanya dalam Marfan dah keluar dah dalam soalan ni. Okay. Next.
A 70-year-old woman presented with sudden onset of breathing difficulty for 1 hour associated with chest discomfort. She had been bedridden for the last 1 week following a fall at home. ECG show sinus tachycardia and right ventricular strain pattern. Select the best diagnostic investigation.
Sekejap. Okay, faham. So the diagnosis is the diagnosis dulu apa?
Bawah sikit slide. B.
What is the diagnosis?
What is the diagnosis?
Jawapan you betul. So diagnosis dia apa?
I'm expecting for pulmonary embolism, Doctor.
Good, very good. Okay, kenapa you tak buat A dengan B?
PE.
Bila you buat A dengan B?
Coronary angiogram.
And what kind of disease you consider for A and B?
Triple vessel disease, Doctor.
Okay, tak payah triple pun lah. Just ischemic heart disease. Okay, ventilation perfusion scan is also a test that we can do to diagnose PE. It's not widely available and it's not as sensitive as CTPA. Okay, lagi?
A 43-year-old man with background history of alcohol abuse was admitted to the ward for further investigation. He presented
You
with 2
seorang je
months.
ke yang duk menjawabnya?
Tak, ada 7 set lagi, ada 6 set lagi doktor.
Oh, okay.
So
Betul?
So he presented with 2-month history of liturgy with reduced effort tolerance. He had also been having intermittent blackish stool for the last 2 months. On examination, he was pale, jaundiced, but afebrile. The day after the admission, the patient became restless and disoriented. Select the likely cause of his deteriorations. B. Hepatic encephalopathy.
Why?
Because acute liver failure due to the alcoholic use. And then kalau meningitis, patient usually had fever kot. And then for mine also photosensitivity.
Okay, so meningitis salah. Why is it not A and D?
Is it because patient still in alcohol abuse? Macam kalau A tu dia usually dapat after dia dah withdraw alcohol.
Betul. Kalau D?
Kalau D tak ada GI punya bleeding.
Sekejap bagi I fikir je. What's the usual presentation for Wernicke's encephalopathy? You buka dalam you punya Hospital Handbook tu.
If I'm not mistaken, Wernicke will have oculomotor dysfunction.
Ophthalmoplegia, ataxia and confusion. Okay. Classic triad. Alright. Okay lah. I think you are correct lah, betul lah. So maksudnya this patient, dia memang ada alcohol abuse and hence dia ada liver failure, dia ada probably dah ada some sort of liver cirrhosis. Sebab tu dia ada esophageal varices. Sebab tu dia ada intermittent blackish stool for the last 2 months. Okay. And the history is a bit too long to say that it's Wernicke's or delirium tremens. Kalau delirium tremens definitely we will give you, dia akan jadi jittery macam tu, macam jittery lah, jittery. Okay, so this one jaundice, so that's more towards liver cirrhosis or something. Okay lah, betul lah, hepatic and enceph. Alright, good. Next.
Okay, so a 60-year-old man presented with tingling numbness over the lower limb and palpitations. He had a partial gastrectomy done 20 years ago for stomach ulcers. So on examination, he was pale, afebrile with blood pressure of 120 over 76 and pulse rate of 110 beats per minute. So select the best investigation to determine the cause of his presentation. So for this, I'll go with D, vitamin B12 level.
Okay, why?
Because he had partial gastrectomy, so that means lesser absorption of B12, and also tingling numbness, suggestive of vitamin B12 deficiency.
Good. Okay. So when do you do, in what disease do you do ferritin level? So now we are talking about anemia.
Yeah,
This is
anemia.
under the topic of anemia. So kalau ferritin level, which type of anemia?
Megaloblastic.
Megaloblastic. Ferritin is your iron deficiency anemia. Thyroid,
Okay.
obviously semua you kena buat full blood picture. Nak tengok sama ada dia mega
Doktor,
or dia
Doktor ada
minor.
cakap ke? Sebab kita orang masih tak dengar.
Hello, dengar tak? Hello?
Dengar doktor, dengar.
Okay. So ferritin usually if you are suspecting IDA, so it's a test, one of the tests you have to send for IDA. Kalau for obviously all and then thyroid function test is for macrocytic punya anemia. Okay. Usually ada presentation symptoms of anemia. Symptoms of anemia pula, symptoms of hypothyroidism. Hypo not hyper. For blood picture definitely you have to send for everyone, but it's not the diagnostic lah. Macam tu. Okay. Good. So the other way that we can ask this question is what would be the best management. So in this case, the answer would be vitamin B12 supplementation. Okay, good. Next.
Okay, a 28-year-old man presented with bilateral feet and hand tingling to his family doctor 4 days ago. Over the next few days, he presented to ED with progressive weakness over both his leg and arm and slurring of speech. On examination, the muscle power in his bilateral lower limb is 0/5 and 1/5 in his upper limb bilaterally. Reflex were absent. Select the most likely diagnosis: A. Guillain-Barré syndrome, because the progressive weakness from the lower limb to upper limb. To untuk cancelkan B, B usually come with upper and lower motor neuron presentations, and then for stroke, usually it's upper motor neuron lesions.
Okay, and it's kalau stroke is usually acute, onset, and unilateral, not bilateral, and somebody who is older. Okay. What about C, myasthenia gravis? What would be the usual presentation?
Okay. For myasthenia gravis, usually it is localized and patient will be fatigued.
Okay, so the fatigue is usually worse in the evening. When you say it's localized, what do you mean it's localized?
Macam patient ni kan dia bilateral, macam myasthenia gravis, it will be unilateral.
Myasthenia gravis is also bilateral, but the usual presentation is they will present to us complaining of inability to open their eyes at the end of the day, or inability feel so tired at the end of the day, or inability to lift up their hands at the end of the day. Selalunya the stem tu adalah in the evening or at the end of the day. So what would be the diagnostic test dalam GBS?
Cerebrospinal fluid untuk tengok albuminocytology dissociation.
I have a feeling it's nerve conduction study. So you all check back again. Nanti I try tanya again neuro juga.
Can also look to the nerve conduction because it will be decreased nerve conduction velocity due to the dilation.
Sebab kalau dalam STEM nanti kalau you dapat dalam exam you Soalan kita orang tanya adalah what would be the diagnostic test. Kita orang letak LP dengan kita orang letak nerve conduction study. So which one would you choose?
Nerve conduction study.
Aku rasa tak apa. Nanti I get back to you lepas neuro jawab apa. Okay, next.
Okay, a 31-year-old was referred for evaluation of his elevated blood pressure. Both of his parents had diabetes mellitus. On examination, he had central obesity with a body mass index of 32 kg per meter squared. His blood pressure was 142/90 and pulse rate was 88 beats per minute. His fasting glucose and HbA1c were 6.5 and 5.9 respectively. So select the best relevant supportive investigation. So the answer would be lipid profile. Because he's having central obesity with high BMI lah. So he also have elevated blood pressure and type 1 diabetes mellitus feature.
Type 1?
Yeah.
Type 1 ke type 2? Type 2.
Yeah, central obesity, so type 2.
Okay, so why do you want to sign lipid profile?
Because
your answer is correct, but why do you
Yeah.
want to sign lipid profile?
because high lipid is one of the risk factor for elevated blood pressure and also arteriovascular disease.
What hyperlipidemia is a risk factor for atherosclerotic disease, but it's not a risk factor for high blood pressure. What syndrome are you talking? Are we dealing with here? There's a syndrome. May?
Dyslipidemia also can cause hypertension.
Dyslipidemia is more of atherosclerosis. Hypertension, usually the pathogenesis is the salt retention, the cardiac hypertrophy. That's hypertension. When you have central obesity and then you have hypertension and then you have diabetes, and now you want to rule out whether there is dyslipidemia, and let's say this patient has dyslipidemia. If they have the constellation of these 4 diseases, we are talking about one particular syndrome. What syndrome is that?
Metabolic syndrome.
Good, metabolic syndrome. What about D? What is saline suppression test?
To check for the levels of aldosterone.
Saline suppression test.
And renin.
And for what syndrome is that?
For Conn syndrome.
Okay, good. Next.
A 50-year-old chronic smoker presented with his third episode of pleuritic chest pain associated with shortness of breath. On examination, he was tachypneic with oxygen saturation of 92% under room air. Lung examination demonstrated reduced breath sound on the left with hyperresonant on percussion. Select the best investigation to investigate the underlying cause of his presentations. We go with C, doctor. High resolution computed tomography of thorax because I'm expecting patient to have pneumothorax.
Okay, baca sekejap.
Okay.
A 50-year-old chronic smoker presented with third episode of pleuritic chest pain associated with SOP. underlying cause of his okay. Betul, jawapan dia betul. You are saying, okay, jawapan dia betul tapi ada tweak sikit dekat situ sebab you are thinking about pneumothorax. But the soalan is not actually asking the best investigation to diagnose. The best investigation, ayat dia kalau you baca betul-betul, select the best investigation to investigate the underlying cause of his presentation. Dia bukan nak tanya pasal pneumothorax tu, dia nak tanya pasal the risk factor of pneumothorax. Sebab kalau the best investigation to diagnose pneumothorax, the answer should be only a chest x-ray will be adequate, and then kita boleh proceed whatever we want to do. This patient, dia datang dengan 3 kali dah episode of pneumothorax. So what is the risk factor yang probably this patient ada? Yang predispose dia tu dapat?
Pulmonary fibrosis.
Okay,
Itu
selain
dia concern misteri.
lagi?
COPD.
Betul, COPD boleh. Pulmonary fibrosis boleh. Satu lagi?
Cancer.
Okay, boleh, tak ada masalah. Satu lagi is bronchiectasis pun boleh. Okay, betul. Jawapan dia, I agree with you. So HRCT will be the best one to go. Okay, next.
A 70-year-old woman with history of ischemic cardiomyopathy presented with worsening dyspnea and bilateral leg swelling. On examination, her blood pressure was 110/70 and her pulse rate was 145 beats per minute. Irregular, and her jugular venous pressure was raised and lung auscultation revealed inspiratory crepitation up to mid-zone bilaterally. So select the most likely cause of her presentation. The answer is atrial fibrillation. Because the keyword irregular, and also, his her chief complaint lah.
Sekejap. You bubuh jawapan?
AFib. P. So dia ada features of pulmonary edema.
Oh.
And her beats are irregularly irregular.
Okay. Okay, kenapa is not MI?
So chief complaint dia normally chest pain lah for MI.
Okay, betul. What about thyrotoxicosis?
Toxicosis tak ada crepitation, inspiratory crepitation, which is sign of pulmonary edema.
Thyrotoxicosis, you can still get thyrotoxicosis cardiomyopathy. So you can still have pulmonary edema. Tapi this one, the reason why it's not, usually for thyrotoxicosis, it won't be this old lah. Usually younger, and kita takkan dapat awal-awal lah, the ischemic cardiomyopathy tu. This one we know is IHD punya underlying cause. Okay, lagi?
Work competency tu not irregular, so we can rule out that.
Betul? Boleh irregular, but usually is for mitral valve involvement lah, either is mitral stenosis ataupun mitral regurgitation. But the presentation tu tak kena lah sebenarnya.
Okay.
Okay, next. 33 38-year-old man who worked with air conditioning service company presented with 4-day history of cough, fever and vomiting. On examination, he was febrile with temperature 38.3 degrees Celsius, blood pressure 120/80 millimeter mercury, and pulse rate was 90 beats per minute. Auscultation revealed left lower zone cause crepitations. Select the most likely organism. D. Legionella pneumophila.
Okay.
Pneumophila. Yes, pneumophila.
The other presentation that we would normally put for Legionella is somebody who has just came back from holiday in macam contoh European countries like or Eastern European countries contohnya like Spain, Ukraine macam tu. Okay, something that has to do with cold environment, air condition. Chlamydia usually what's the risk factor?
The mode of transmission tu, usually it is transmitted by snooze and also cough.
Semua orang nose dengan cough. SP. Chlamydia is usually from burung kan, tak salah I. Ini you all kena check dalam Oxford Handbook tu dia ada satu section for atypical pneumonia tu. Klebsiella, Chlamydia, Staph aureus. Macam kalau Klebsiella if I'm not mistaken is usually in alcoholic. Staph aureus can also happen in alcoholic juga. But Staph aureus sometimes can happen for example in those yang duduk kat nursing home so they can get MSSA. Lepas tu Klebsiella, Pseudomonas. Pseudomonas is the typical history yang kita akan letak dalam stem somebody yang memang ada chronic lung condition. So dia ada greenish sputum. So something like cystic fibrosis or any other types of bronchiectasis, so they prone to get Pseudomonas infection. Aspergillosis is usually somebody yang kerja farmer, yang involved dengan binatang, especially like birds, ataupun farmer yang macam banyak involved dengan all those debu-debu. So that's aspergillosis. Atypical mycobacterium, actually tak payah tahu sebenarnya atypical mycobacterium. There are 4 big groups of atypical mycobacterium. The presentation for atypical mycobacterium is usually cutaneous. They normally have some ulcer ke ataupun they have like skin lesion dekat kaki dengan tangan ke, and then not necessarily they will have lung unless we are talking about Mycobacterium avium complex ataupun Mycobacterium haemophilum, something macam tu. So these two usually in those who are immunocompromised. History dia kalau atypical Mycobacterium adalah dia ada immunocompromised. Okay, next.
A 73-year-old man presented with slurred speech for the past 6 hours. His past medical history included hypertension and atrial fibrillation on warfarin. On examination, his blood pressure was 160/90 and pulse rate was 89 beats per minute, irregular. He had mild ptosis of his left eye and was unable to move his left facial muscles. So select the immediate investigation. So his symptoms are suggestive of stroke. So I'll go for computed tomography scan of brain. C.
Betul. Okay lah, this one quite straightforward. Next.
Yeah.
Okay. A 48-year-old man presented with hematemesis for the last 2 days. He denied abdominal pain and weight loss. On examination, he was febrile with BP 100/80 millimeter mercury and pulse rate of 90 beats per minute. There was fullness fell over the left upper quadrant of the abdomen. Okay, so lab investigation, anemic, normal white cell count, platelet normal, sodium normal, potassium normal, creatinine, I think normal also. And then hepatic ultrasound, liver cirrhosis and splenomegaly. Select the most likely diagnosis, esophageal varices.
Betul? So Mallory Weiss test, usually the typical presentation memang kita akan letak frequent sudden onset, frequent episode of retching or vomiting, acute onset. Pada pecah lah tear tu. Esophageal cancer, you akan ada constitutional symptoms, ada dysphagia. Peptic ulcer disease akan ada burning pain, etc. Betul lah. And then the history probably something like on steroid or painkillers. Okay, the other question that we can ask in this case is what is the diagnostic investigation lah. The answer would be endoscopy. I think that's all. Okay. Tadi ada tanya gang neuro. So actually betul kat you Haziq, memang kita kena buat dua-dua. LP pun kena buat, NCS pun kena buat. So kalau dalam SBAQ, we won't put both at the same time. We will put one. So kalau ada LP, you choose LP. Kalau ada NCS, you choose NCS. Okay.
For the first question, a 60-year-old man presented with chest pain and worsening shortness of breath for 2 weeks. On examination, his blood pressure was 80/50, hypertension, pulse rate was tachycardia, and respiratory rate was normal with oxygen saturation of 95% under room air. And his JVP was raised and precordium examination revealed soft heart sounds. So for the most likely diagnosis, I think it's decompensated heart failure.
Salah. Why you think it's decompensated heart failure?
Because I think it's for 2 weeks, so it's quite a long period of time, and then
Tapi why do you think we put soft heart sounds? There's only one thing je if you have soft heart sounds.
The cardiac tamponade, is it, doctor? Like the heart tamponade.
Yes.
But I thought cardiac tamponade is like acute time, so like should happen like immediately, not for 2 weeks.
The 2 weeks patient will have a pericardial effusion, but then present with cardiac tamponade.
Okay.
Faham? Okay.
Okay.
Pulmonary embolism, semua presentation tu boleh dapat, kecuali start akan dapat soft heart sound lah. Instead we will put akan ada, kalau dia ada massive PE, dia boleh dapat all the presentation, but then they will have a loud P2. Acute coronary syndrome memang out of the question lah, sebab dah 2 weeks ni. That one will be acute.
So for the next question, a 70-year-old woman presented with chest pain and difficulty breathing on exertion for the past 3 months. On examination, there was a soft first heart sound and ejection systolic murmur was heard over the right second intercostal space. So for the most likely etiology of the valve abnormality, so I think it's aortic stenosis because of the aortic part and ejection systolic murmur. So the most likely is the degenerative, the calcified aortic stenosis.
Betul?
Mm.
Betul. Okay,
Okay.
next.
Okay. So for the third question, a 50-year-old woman with hypertension presented with worsening shortness of breath for 2 weeks, associated with leg swelling, orthopnea, and PND. On examination, her PAX beat was at 6 intercostal space. It's displaced with the presence of third heart sound. And lungs examination revealed biplacial crepes, and ECG showed Q wave and T wave inversion at V1 to V6. So it's indicating myocardial infarction. So for the best investigation to determine the cause of her presentation is I thought of doing an angio, coronary angiogram.
Sekejap. Naik atas sikit bagi I baca sikit. Hmm. Determine the etiology. Okay, betul. So, tapi kalau soalan dia is select the best investigation of her presentation. Tak ada determine the etiology. You akan ambil apa?
Echo?
Yes,
Echo.
echo. Because you're thinking about what diagnosis? What is the diagnosis of presentation?
It's heart failure.
Good. Okay. So the etiology of this heart failure, you think it's?
It's because of the infarction.
Yes, it's an ischemic. So sebab tu you do coronary angiogram, correct? Okay, good. Okay.
For the next question, a 27-year-old woman presented with bilateral leg swelling, puffy eyes, and multiple joint pain for 3 weeks. She also had a rash over her cheeks with swollen finger joints. So, for the best diagnostic investigation, I was thinking of SLE since got rashes, and so ANA antibody for the investigation to rule out SLE.
Betul. Okay. So, okay, you can, the 24-hour neuroprotein is, obviously you have to send, but it's not diagnostic lah sebab it's only to confirm the diagnosis of nephrotic syndrome. ESR pun sama, it's more of like management. What about rheumatoid factor? Normally for what disease you send for rheumatoid factor?
Rheumatoid arthritis.
Yes, rheumatoid arthritis. Okay. Rheumatoid factor can also be positive in some patients of SLE. Remember that. Okay, but this patient memang very typical of SLE lah. This kind of question selalu masuk exam. Okay, so you have to know that this is a case of SLE with what complication?
Kidney, renal.
Yes, renal involvement.
Nephritis.
Betul? Lupus nephritis. Okay, lagi?
The next question, a 24-year-old woman presented with bilateral lower limb swelling and frothy urine for 3 weeks. On examination, she was febrile with bilateral lower limb edema until her thighs. Her right lower limb was markedly more swollen and was tender to touch. So for her investigation showed proteinuria, and the urine 24-hour protein was high and serum albumin also high. This one I'm not very sure, doctor, because I was thinking of kidney renal failure. So maybe it could be deep vein thrombosis causing like renal failure, but I'm not sure. So thinking maybe B.
Scheme B. Sekejap a 24-year-old woman presented with bilateral lower limb swelling and frothy urine for 3 weeks. Okay. 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 Okay, what is the diagnosis first?
Nephrotic syndrome.
Good. Okay, jawapannya betul. So what, jawapan dia memang DVT. Tapi why is it DVT? What are the
Maybe the DVT caused the block the renal vein and caused the
tak. The nephrotic syndrome ada a few complications, right? One of the complication is they has increased they have increased risk of thrombosis sebab they hilang the clotting factor through the glomerulus whatsoever tu. Just as how much they have an increased risk of infection. Also an increased risk of hypercholesterolemia. So they are, if I'm not mistaken, these are the 3 main complications of nephrotic syndrome that you have to be aware of. So one of the complications yang thrombosis tu sebab tu they are at high risk of getting DVT or any other types of thrombosis. Sebab tu the treatment for them is also to give anticoagulation. Kalau for risk of infection, the treatment is to give vaccination. Kalau hypercholesterolemia, obviously you have to check and then treat accordingly. So patient ni presentation dia awal-awal tu 3 weeks, so unlikely to be DVT. Sebab lama sangat. The presentation is more of nephrotic syndrome. Tapi dia datang dengan complication which is the DVT. Abscess is out of the question sebab patient is afebrile. Cellulitis is also out of question sebab patient is afebrile. Lymphedema is usually the presentation kita sepatutnya one more swollen and tender to touch tadi lah. Lymphedema is usually not swollen. It's swollen but it's not tender to touch.
Okay. So for the next question, a 15-year-old boy presented with a 1-week history of bilateral puffy eyes and frothy urine. On examination, there was facial puffiness and bilateral lower limb edema with normal blood pressure. And his serum albumin was 25, which is high. So for the best diagnostic investigation, since got like frothy urine, so I was thinking of some kidney failure, so 24-hour urine protein to see got renal failure or not on nephrotic syndrome.
Your answer is A.
Yeah, A.
Betul? If this is apa nama betul, it's a diagnosis of nephrotic syndrome, but what diagnosis of nephrotic syndrome? Syndrome kan ada banyak jenis kan?
Is it the minimal change disease, doctor?
Betul, minimal change disease. Okay. So kalau what is the next best management? Kalau dia ada stem dia tu ada renal biopsy. B, start patients on oral steroid. Okay, antara dua tu je. Which one would you choose?
Steroid, doctor.
Betul. You don't actually have to do biopsy. Okay, lagi?
For the next question. A 20-year-old man presented with 6-month history of intermittent dry cough. He was a non-smoker and he had daily bilateral rhinitis and occasionally he developed a pruritic rash in the antecubital fossa whenever he consumed seafood. So, and the physical examination was normal, so for the best diagnostic investigation. So I think since got like allergic reactions to seafood and rhinitis, so asthma, so maybe it could be spirometry.
Okay, so what is the diagnosis yang psoriatic rash tu?
It's an allergic reaction to seafood.
No. What's the dermatology punya diagnosis for that?
Oh. Is it the dermatophytes? Dermato something.
No, it's eczema tu, as Haziq dah jawab.
Oh,
It's
eczema.
eczema lah. So this is a constellation of atopic diseases. So you have asthma, you have allergic rhinitis, and then you have eczema. Psoriatic rash in the anticubital fossa consume seafood. Usually when we say allergic, the presentation is urticaria, which is like gegata tu, or angioedema, sudden. Kalau you have psoriatic rash whenever they consume tu, that's more of increased sensitivity to seafood, not necessarily to the point of having an allergy to seafood. Okay, so why can't you do skin prick test?
Because it's not a confirmatory like for the asthma.
Do you do skin prick test for asthma?
No.
So when do you do skin prick test?
Any allergic reactions?
Yes, skin prick test is when you suspect an immediate hypersensitivity lah. So kalau patient ada number one is cutaneous wise, they have urticaria and angioedema immediately after being exposed to certain triggers lah, which is up to 2 hours. Kalau allergic rhinitis pun they can do skin prick test. Kalau they have like runny nose, rhinorrhea upon consuming certain ataupun exposed to dust macam tu, so they can do skin prick test. Asthma per se, you do skin prick test if let's say dia ada macam some sort of like bronchospasm. So that's a sign of immediate hypersensitivity. But in usual cases, we try to avoid skin prick test kalau dia ada bronchospasm sebab we tak nak patient mati masa tengah buat test tu. So instead you do a serum IgE. Okay. If you were to do a chest radiograph in somebody who has asthma, what findings do you expect to find?
I'm not sure, doctor. Maybe nothing.
Nothing can, or the other one you can get a hyperinflated lung fills.
Okay.
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 And for the next question, a 40-year-old woman presented with pruritic chest pain, productive cough, and high-grade fever for 1 week. On examination, she looked lethargic and dehydrated. Her temperature was 38.5. BP normal and pulse rate was slightly high. There was a cough cramps on her lower left midzone. So for the most immediate investigation, I'll do a chest X-ray.
Yeah. Your diagnosis is?
Bronchiectasis.
Do you think bronchiectasis can present in 1 week? What would be a more likely diagnosis?
How about
Kalau you
pneumonia?
dapat, sorry?
How about pneumonia?
Yes, the answer is pneumonia.
Okay.
So 1 week episode of fever and then ada typical signs of crepitations. So it's pneumonia lah, you have to do a chest radiograph. Okay, good. Jawapan dia B, right, Ibu Bo? Chest radiograph. Okay.
So for the next question, a 25-year-old man presented with sudden onset pruritic chest pain associated with dyspnea for 2 hours. He recently returned from a long-haul flight from Vietnam. On examination, patient was tachypneic with oxygen saturation 92%, reduced air entry on left chest with hyperresonant on percussion. So it's pneumothorax.
Good. Okay. The other stem you can ask this is definitely pulmonary embolism. But kalau for pulmonary embolism, usually again on examination, it can just be normal but just increase in P2 sahaja. And then probably we can letak a bit of tachycardia. Acute heart failure is a bit unlikely lah in somebody who is only 25 years old. And presentation usually for acute heart failure is crepitations. It's pun unlikely lah for somebody who is so young.
So for the next question. A 24-year-old man presented with fever, lethargy, myalgia, and vomiting for 4 days. He had no history of travel or recreational trips in the last 3 months. On examination, temperature was 38.8 degrees, blood pressure normal, heart rate normal, with a capillary refill time also normal, and just generalized blanchable maculopapular rash. And also he had neutropenia and thrombocytopenia. So it's
Okay.
dengue, and since it's 4 days, so we can do NS1 antigen.
This one kena hafal lah. Kena hafal. Soalan ni selalu ulang dalam exam. Okay, so kena hafal benda ni. So NS1 sampai bila, IgM sampai bila, IgG sampai bila. Okay, good. Okay.
And then next question. A 41-year-old woman presented with 6-year history of secondary infertility, irregular menstrual cycle, and galactorrhea, presented with visual disturbance, and so the visual examination revealed bitemporal hemianopia. So I think it's pituitary adenoma because got
Okay.
galactorrhea, so it's compressing the optic nerve and causing bitemporal hemianopia.
Okay, what is the usual presentation for cavernous sinus thrombosis?
Not sure the cavernous sinus.
Cuba tengok dalam Australian book. What is the usual presentation for cavernous sinus thrombosis?
Is it papilloedema?
Usually for cavernous sinus thrombosis, it's they will present with bulging.
Eyes.
Yes. So kan, correct me if I'm wrong. They
Yeah.
normally present with proptosis and ophthalmoplegia. Brainstem stroke, normally they present with it can be bilateral punya onset weakness pada brainstem. Brain malignancy obviously a much longer onset. Boleh je sampai 6 years, tapi usually dia akan ada headache, increase in ICP symptoms. Alright, older age.
Okay, and then next question. A 31-year-old man referred for an elevated blood pressure. On examination, he was obese, BP high, pulse rate normal. He had central obesity, otherwise everything normal. His fasting blood glucose was 6.5, which is high, and HbA.
Ulang.
So he was diabetic, and so the most likely explanation for his high blood pressure will be the metabolic syndrome.
Ini soalan sama yang Vicky cakap tadi. Nampak tak the way we tweak the soalan to be a bit different?
Yeah.
Okay.
Okay. So for the next question, a 26-year-old housewife presented with 4-hour history of abdominal pain associated with nausea and vomiting. She was feeling more tired than usual for the 1 month, and she was drowsy. She was dehydrated and febrile. BP was 100/60, which is low, and also while she's lying, and 80/40 while sitting. So she has hypertension. Pulse rate was 120 high, and her systemic examination were normal. So the blood investigation revealed glucose is high and ketones were also high, and she was having acidosis, and the bicarbs were low. So I think it's diabetic ketoacidosis.
Correct. Kalau HHS,
HSS,
Hmm.
yeah, the ketones should be more than 30 if I'm not mistaken. Should be very high.
Okay. Kalau satu lagi, kalau for HSS to make it fair to you all, how old is the patient?
26.
HSS is usually much older. It's in type 2 diabetes. Okay, just we may not ask, but just be prepared sajalah. You just be prepared to know how to measure, how to calculate for serum osmolality. The two in bracket, sodium plus potassium plus glucose plus urea, if I'm not mistaken. And the value should be 280 to 290, if I'm not mistaken. But please have a look and just memorize that for the exam in case. Okay. Tapi kalau tak bagi the value tu, it's unlikely to be HSS, because for HSS you kena calculate the value. Okay. Kalau Addisonian crisis, kalau Addisonian crisis, they presentation macam ni boleh jadi Addisonian crisis. They can get postural hypotension, nausea, vomiting. But usually kalau for Addisonian crisis, kita akan letak value potassium. Potassium dia akan tinggi, kan? Sodium dia a bit lowish, glucose dia akan jadi low. Hypoglycemia. Pancreatitis a bit unlikely lah, sakit perut pasal ever. Okay. Okay.
So for the next question, a 28-year-old man presented with left foot weakness with paresthesia for the last 2 weeks. She had a similar presentation 2 years ago with complete recovery. On examination, she was not able to dorsiflex and evert her left foot. There was reduced sensation at the anterolateral aspect of her leg, but her reflexes were all normal. So for the best diagnostic investigation, I think of nerve conduction study, because she has like loss of sensation.
But what is the diagnosis?
Peripheral neuropathy.
Secondary tu?
I'm not sure of this course, doctor, but she had a similar presentation 2 years ago. I'm not sure.
I think the answer memang betul. Memang nerve conduction study. Ataupun sekejap. We know that the patient has problem, patient ni ada foot drop. Tapi what is the cause? Is it something that has to do dengan
nerve problems? So it's a neuropathy.
Yes, so yelah, I mean, would doing a nerve conduction, sebab the causes of foot drop can be a few, right? The problem can either be, for example, boleh jadi trauma dekat kawasan tibia fibula, that can be one of the cause, or it can be problem higher up dekat kawasan spine, ataupun it can be something like mononeuritis punya problem, so it comes and go. I pun tak sure, tak apalah, I try tanya again neuro lah, nanti I get back to you.
Okay, for the next question, a 16-year-old girl presented with temporary loss of consciousness for 5 seconds following prolonged standing. According to eyewitness, she was sweating prior to falling, but here was no abnormal movements or tongue biting during the episode and regained full consciousness thereafter. On examination, she was alert with normal vital signs. So for the most likely diagnosis, it's vasovagal syncope because of the short period of loss of consciousness and sweating.
Betul. This one you all belajar kan dalam you all punya tutorial ke lecture? Macam mana nak bezakan epilepsy from the other causes of loss of consciousness tu, the other causes of syncope?
Yeah, I think so.
Ni kena tahu ni sebab this is a favourite question for SAQ juga sebenarnya. Okay. Kalau postural hypotension, usually the history is somebody yang duduk tiba-tiba bangun. Somebody who has been on antihypertensive, particularly something like prazosin macam tu. Epilepsy dalam kes ni is unlikely sebab they regain full consciousness straight away. Okay. And obviously kalau epilepsy kita akan letak abnormal movement semua tu lah. Cardiogenic syncope usually preceded by exertion. So ada chest pain, ada shortness of breath.
Okay. So for the next question, an 18-year-old woman presented for medical screening for university admission. She had a sister who is on regular blood transfusion. So for the hemoglobin, it was very low. She was anemic, and MCV was also low. So it's microcytic anemia. So for the most appropriate next investigation, I was thinking of serum iron to see iron deficiency anemia.
Dah ada ferritin dah tu. And then ada history, ada sister pula yang ada.
Oh, thalassemia. So it's hemoglobin electrophoresis.
Betul. There's a reason why we give ferritin and there's a reason why we give family history. Kalau SBAQ you dapat anemia and you ada family history, it's thalassemia until proven otherwise. Okay.
Okay, so for the next question, 15-year-old girl presented with lethargy for 6 months and she was pale, had cracked lips over both angle of mouth with spoon-like fingernails, koilonychia. So for the best diagnostic investigation, this one I'm not sure because it's anemia, but maybe ferritin, serum ferritin.
Cracked lips over both angles of the
mouth.
Kalau the koilonychia memang it's IDA. Tapi why do we put cracked lips? Sebab kalau cracked lips, then we are actually thinking about okay. We are thinking kalau cracked lips, we are thinking about angular stomatitis, which can happen with Crohn's disease. So in Crohn's disease memang diorang boleh dapat they can get IDA. Betul? So the cracked lips tu is the angular stomatitis. So the underlying disease for this patient is actually is either Crohn's ataupun satu lagi is celiac disease.
Okay. So it's betul? Iron deficiency anemia.
Betul? Koilonychia is usually iron lah. Spoon nail tu.
So for the best diagnostic, we do serum iron or serum ferritin.
We do serum iron.
Okay. So for the next question, a 30-year-old man presented with 2-month history of diarrhea, weight loss with foul-smelling floating stool. On examination, there was an itchy, blistering skin rash over the abdomen with peripheral neuropathy. So for the most likely diagnosis, I was thinking of TB since got many
No.
systemic presentations.
No. Tell me, kenapa dia ada that itchy, blistering skin rash tu? Okay, sekarang ni dia ada foul smelling. Okay lah, dia one the word foul smelling tu, dia ada floating stool. Kalau if a patient has floating stool, it indicates what? Does our stool float?
The fatty stools, is it?
Yes. Okay,
Like-
betul. Okay, betul. So, okay, what does it indicate then? Why would a patient has a fatty stool?
Because they have like the fats cannot be digested.
Yes.
So-
So what is that? It falls under what? Faham tak masalah GI tu? GI tu penyakit dia bahagian apa? Kan ada banyak penyakit bahagian GI kan? Is it apa guys? Apa GI bleed ke? Is it colon cancer ke? Is it malabsorption ke?
I think maybe malabsorption.
Good. Okay, malabsorption. So kalau dia malabsorption, so what are the diseases in malabsorption that you know of?
TB. I thought TB can cause malabsorption.
TB can cause malabsorption, tapi okay, selain TB, Crohn's can, lagi? Why do you think there is a step? Everything dalam STEM tu has to make sense. Why, if let's say you are saying that there is an itchy, blistering skin rash, kenapa? Apa kaitan tu dengan TB? There's nothing incidental on the STEM. Tak ada saja kita letak. Kita letak tu sebab kita nak tolong you all come to the diagnosis.
Is it the Whipple disease?
Tak. Whipple disease is usually tu yang letak tu is a bacteria punya infection. So usually jadi dekat area macam kat US betul. Okay, it's more systemic. Lagi? What is that one malabsorption punya disease yang ada dermatology punya manifestation, which is an itchy, blistering skin rash?
Ulcerative colitis, doktor, ada ke?
Tak. Ulcerative colitis, dia punya dermatology punya presentation is it's an ulcer. It's a pyoderma gangrenosum. Usually dekat anterior shin. The answer is celiac disease because the itchy, blistering skin rash is dermatitis herpetiformis. Nanti you all just Google up the picture. They typically present with dia memang very phtognomonic. Patient memang ada diarrhea and at the same time dia ada this itchy skin rash dekat kawasan extensor of elbows, dekat kawasan abdomen, dekat kawasan lower back. And why do you think they have peripheral neuropathy? Dalam kes ni. Tu cakap with peripheral neuropathy. So kalau dia ada malabsorption, what else can they have reduced in? Tadi dah sebut
Vitamins.
Which vitamin?
B12.
Okay, so B12 boleh, B1 boleh, B6 boleh. So basically vitamin B lah punya deficiency. So the answer is celiac disease. Okay, kalau tuberculosis, the presentation diarrhea, weight loss boleh, tapi TB colon is a bit too
Rare.
presentation for a TB colon. Usually they will have some recipe punya presentation juga at the same time, unless of course if they are immunocompromised. Okay.
Okay. So for the next question, a 59-year-old man presented with a postprandial burning sensation in the retrosternal region for the last 6 weeks. He had occasional bitterness sensation in his mouth mixed with small amount of undigested food. So it's a GERD disease, and for the best diagnostic investigation is the ambulatory pH monitoring.
Presented with a postprandial burning sensation in the retrosternal region.
And also bitterness in the mouth.
Your diagnosis is what?
Good. Reflux.
GERD. Oh, okay. I dengar you sebut grave disease. Okay. So your select the best diagnostic test.
The pH monitoring.
Betul. Okay. I rasa betul. Urea breath test is basically if you're thinking about H. pylori. Apa sekejap bagi I confirm sekejap dengan gastro. Okay lagi? Kita kena stop at 11:45 sebab I have teaching.
Oh, okay, doctor.
Oh, by the way, the answer for the... Sekejap. Tak apa, teruskan dulu. Okay, next one.
Does Haziq wants to continue? Haziq? Haziq?
Abi boleh tak pergi set 7?
Set 7. Okay.
A patient presented with heartburn and regurgitation for 3 weeks but cannot be relieved by proton pump inhibitors. Patient has loss of weight of 5 kg, loss of appetite in the past 3 weeks. Currently, the patient has difficulty swallowing. So the best diagnostic investigation would be upper endoscopy because I suspect the patient has GERD.
Memang betul patient ada GERD, tapi what is a more red flag punya diagnosis in this case? Dia ada difficulty swallowing and then dia ada constitutional symptoms and then GERD dia tu tak settle dengan PPI alone.
Maybe the patient has acalosia?
No. Kalau you rasa, kalau diagnosis you GERD, you buat pH probe lah kan? Tadi kan kita dah discuss.
Oh, okay.
So jawapan dia memang betul, upper endoscopy. Tapi you nak I nak make sure you dapat the correct diagnosis dulu. Cepat. Constitutional symptoms, kalau constitutional symptoms satu benda je pun. Dengan dysphagia.
Is it a cancer, doctor?
Yes. It's a esophageal cancer. Before patient progress to esophageal cancer, they will have Barrett's esophagus. So the diagnosis in this case is not GERD anymore. The symptoms are symptoms of GERD initially, but if you remember kalau GERD, kalau dia tak ada red flags, you all belajar kan? I remember Dr. Suyun once told me, memang dia ajar you all. Kalau GERD tu memang tak ada red flag symptoms, just like tak ada constitution symptom, you boleh trial dengan treatment dulu. You tak payah terus buat endoskopi or pH probe semua tu, you boleh bagi ubat dulu. Tapi if let's say dia dah on ubat tapi tak hilang, and then dia ada constitutional symptoms, and then dia ada dysphagia, that is significant to tell us that probably this patient dah progress to malignancy. Okay, so dia akan start, bila dia buat tu, dia akan dapat Barrett's esophagus, and then subsequently dia boleh dapat esophageal cancer. Okay, barium swallow usually you nak tengok apa?
Nak tengok to diagnose GERD ulcer or dysphagia.
GERD you tak guna barium swallow. Diaphragmatic hernia, not so much. Usually kalau barium swallow ni is more of kalau nak tengok kalau cancer boleh. Kalau nak tengok for stricture boleh. Esophageal stricture. Okay, lagi?
Next question. A 30-year-old woman came in with right knee swelling. She complained of prolonged menstrual bleeding. Her blood results are as follows: prolonged bleeding time, prolonged APTT, and hemorrhagic synovial fluid. So my answer is hemophilia.
Betul? So thalassemia, they don't present with, it's not a bleeding punya problem, it's only anemia. Von Willebrand disease, usually they present with cutaneous manifestation. So something like just petechiae or ecchymosis macam tu. Same like ITP. And of course the blood result for ITP dengan VWD tadi kita dah discuss kan. Okay, next.
A 48-year-old man presented with a seizure for 10 minutes. He has a previous history of epilepsy. Physical examination shows a GCS is 5. Her blood glucose shows 3.8 millimole per liter. The best diagnosis is status epilepticus.
What's the definition for status epilepticus?
The seizures last longer than 5 minutes, and the patient will have more than one seizure within a 5 minutes period.
Betul? Ataupun it's a recurrent seizure with no recovery in between kan?
Betul.
Blood glucose shows 3.8 Actually anything less than 4 dah boleh kira sebagai hypoglycemia dah sebenarnya. Bukan less than 3. Cuma I rasa yalah the best diagnosis will be status epilepticus lah. Maybe the hypo juga that will precipitate his status epilepticus. But it's more important to be able to see that it's status epilepticus in this case. Okay, I setuju. Next.
A 32-year-old man came in with a diffuse tender anterior neck swelling with dysphagia. Lab result shows elevated T4 and suppressed TSH 2 days after admission. 2 weeks later, his thyroid function test is normal. So my diagnosis is decalvent thyroiditis. Because I think it is viral.
Betul. Betul. Because it's only temporary, so thyroiditis, decalvent thyroiditis. Graves' disease is usually it wouldn't resolve as fast, and it's not tender. Hashimoto betul is more of hypothyroidism, and usually women around 40 years of age because it's autoimmune. Multinodular goiter, elderly boleh, tapi 40-50s pun dah start nampak dah sebenarnya multinodular goiter. And again, it's a toxic punya hyperthyroidism, so it doesn't resolve spontaneously macam ni. Okay.
Next, a 32-year-old male came in with unilateral muscle wasting. Upon physical examination, his sensory was intact. He states there was a previous childhood disease. He has used calipers since then. The diagnosis is poliomyelitis.
Poliomyelitis. He has used calipers tu apa?
Yang walking aid tu doktor, untuk tolong dia jalan.
Calipers. Oh, okay. Betul lah. Kalau cerebral palsy, what would be their usual presentation?
Hypotonia?
Yes, cerebral palsy not necessarily hypotonia, it's actually dah jadi upper motor neuron. So usually the presentation dia memang congenital daripada kecil. So kita tak akan letak previous childhood disease lah, kita akan cakap since birth macam tu. Usually it's a consequence of, for example, brain hypoxia during delivery. Common peroneal palsy is foot drop. So yang patient yang tadi yang kita discuss yang Abi punya case tu, foot drop tu memang jawapan dia NCS, neuro baru reply dekat I. It can be recurrent. So polio, yalah polio the other way is sometimes bisa kat kaki, kat tangan pun boleh. Ada patient polio tangan masuk exam.
Doktor, maksudnya cerebral palsy akan ada hypotonia dan hyperreflexia semua tu ke?
Yes. Spinal cord compression is upper motor neuron lah. Tapi you have sensory level. Bukan sensory level yang ada ajar you all. I remember I taught you all dalam MedWatts 1 hari tu, sensory level. Not just impact sensation with sensory level. Kalau tak ada sensory level, maksudnya the problem is in the brain. Kalau sensory level, maksudnya the problem is in the spine. Okay, next.
Next, a 42-year-old woman presents with weakness in her left arm and leg. Physical examination shows a power of 2/5. She presents with a weak gait reflex. After 2 days of admission, she develops a cough with productive sputum. She later develops pneumonia. The type of pneumonia the patient has is aspiration pneumonia.
The weak gait reflex and the weakness left arm and leg tu diagnosis adalah kenapa patient dapat aspiration pneumonia? Kawan you dah tulis dah tu.
Sebab stroke.
Sebab stroke. So atypical pneumonia tadi kita dah ada suruh you all balik baca kan, the different types of atypical pneumonia dalam Oxford tu. Community acquired typical presentation, kita akan letaklah stroke sebelum tu. Hospital acquired usually after 3 days onwards baru kita consider hospital acquired pneumonia. Okay, up until 2 weeks if I'm not mistaken. There's a definition for HAP, nanti you all kena go back and check. Okay.
Next, a 71-year-old man is a chronic smoker. He has worked as a contractor for 30 years. On physical examination, he presented with stony dullness on the lower left chest with hyperresonance. My answer is mesothelioma.
Betul. So remember the differential diagnosis for for dullness in particular. Dullness in the lower zones. Satu is pleural effusion. Number 2 is disease of the pleura. So like your mesothelioma. Number three adalah raised diaphragm. Raised diaphragm, especially those yang ada nerve palsy, diaphragmatic nerve palsy tu. Okay. Alright, good. Lagi?
Next is, the question is not complete, but the potassium is 6.9, which is hyperkalemia. The blood glucose is 33 millimole per liter. My initial management would be IV normal saline to hydrate the patient. To give hydration to the patient.
I rasa kalau STEM ni ada kalau STEM ni cakap pasal, okay, STEM ni can be both HSS dengan DKA. Tapi whenever you see a patient with HSS dengan DKA, you kena tengok dia punya macam nak cakap dia punya other acute presentation yang lain juga. So dalam kes ni dia ada acute hyperkalemia. So antara contohnya katalah let's say patient ni ada HSS. So fine, dia memang ada hyperglycemia. Tapi antara hyperglycemia dengan hyperkalemia, which one yang patient akan mati dulu?
Hyperkalemia.
So kalau hyperkalemia, jawab my answer in this case the answer should be calcium gluconate. Because calcium gluconate, the action is mainly for you to, it's a cardiac membrane punya stabilizer. So they prevent the onset of ventricular arrhythmia. So that's sebab tu dia it's a medication in life threatening hyperkalemia. Tapi kalau tak ada calcium gluconate, definitely lah jawapan dia is IV drip.
Okay, doktor.
Okay. The reason why we put insulin injection here is number one is to reduce hyperglycemia. The other one, insulin can also be a treatment for hyperkalemia juga, but it's slow. I don't think this patient ada HSS lah. Kalau jawapan dia D, ada sodium bicarb, most likely the stem is on DKA. So you never give sodium bicarb. I wouldn't say you never give. In very acute severe cases where you also have concurrent AKI, you memang tak respond to IV drip, ada je boleh bagi sodium bicarb. Tapi that one is beyond you all lah. You all punya treatment kalau for DKA dengan HSS is always IV drip and insulin. Okay, the other treatment for hyperkalemia is you can give nebulizer, particularly the salbutamol nebulizer. And then you kena bagi calcium binding medication lah, like your apa nama dia tak ingat. Calimate. Oral calimate. KALIMATE. Okay, lagi?
Okay. Next, a 60-year-old man presents with stiffness early in the mornings. He complains of pain in both his hands, especially around his fingers. He appears generally catasic and unwell. The best diagnostic investigation would be rheumatoid factor. Good.
What is anti-neutrophil cytoplasmic antibody?
It is used to diagnose autoimmune vasculitis.
For example?
Ischemic bowel disease.
No.
Crohn's disease.
No. What is more specific for angka? You have vagus, granulomatosis, and Schistros. So angka dia ada P angka and C angka. So different disease akan ada predominant of C angka, different disease akan ada predominant of P angka. Benda-benda lain pun boleh ada angka juga, but these two yang selalunya akan kita orang tanya dekat student lah. Vagus and satu lagi Schistros.
Itu macam mana doktor?
CHURG dash STRAUSS. Different disease will have different predominant angka. Macam I tak ingat salah satu vagus, if I'm not mistaken, it's P. Maybe I'm wrong, tapi you all have to check. Macam tu. Kalau Schistros, yang lain lah macam tu. What about anti-Smith antibody? What is that suggestive of?
SLE?
SLE, yes, that is more specific for SLE as compared to anti-nuclear antibody. Okay, last one dulu, kita stop supaya ada teaching dengan MMed pula.
A 28-year-old woman has a known history of breast cancer. She had a right mastectomy done. Currently, she presented with shortness of breath. Upon auscultation, her lungs were clear and she had a soft heart sound. Her blood pressure was 90/60 mmHg and her pulse rate was 100 beats per minute. What is the most relevant investigations? The echocardiogram.
Sekejap.
Actually, this question macam saya tak pasti apa problem dia.
I rasa dia nak cakap pasal pulmonary embolism. So dia sebab history of malignancy and then present with SOB and then the slight tachycardia. Tapi why is it soft heart sound tu I tak sure. Sebab I don't think echo would do any good. It doesn't sound like pericardial effusion to me.
Macam tu kena buat D-dimer ke untuk?
I rasa susah lah soalan ni sebab you tak ada presentation shortness of breath tu berapa lama. Kalau shortness of breath tu has been going on for a while, then it can still be pericardial effusion sebab it can be malignant pericardial effusion secondary to breast CA. So echo would be the best answer. That can explain the soft heart sound. Tapi if let's say it's a sudden onset shortness of breath, I will go for CTPA. Tak payah, you all tak payah pening lah soalan macam ni. You all fikir macam tu je. Kalau lah soalan ni keluar dalam exam. Sebab this one tak complete kan soalan. Senior bagi kan. So kalau lah soalan macam ni, if let's say shortness of breath tu acute, then jawapan adalah CTPA. Kalau you suspect PE, you never do D-dimer, you straight away do CTPA. D-dimer definitely will be risk in somebody yang ada malignancy. Okay. Kalau presentation of shortness of breath having macam subacute macam 2 weeks macam tu, then you think about malignant pleural effusion. In that case, the best test is to do an echocardiogram. Okay. Kita stop dulu.